So our exam 3 is this Thursday and Friday. You guys are welcome to attend the Thursday 4 o'clock testing time if you want, or can be here for Friday at noon. So, okay, let's go ahead and start the digestive system. Now, I love food, so we're going to learn all about the digestive processes of food and more. Let's go over the digestive system, commonly referred to as gastrointestinal tract. It's more than just the gastrointestinal tract because we actually have some additional organs that are actually not part of the tube, and those are called the accessory digestive organs. So gastrointestinal tract is going to start off with the oral cavity. Then it will be our pharynx, then the esophagus, then food goes into the stomach, the small intestine, the large intestine, and out the anal canal. The gastrointestinal tract is often called a continuous coiled tube from mouth to anus whose lumen is considered outside the body. The reason for this is you can easily get into it. When we talk about lumens of glands, it's not easy to get into a lumen of a gland. We talk about the lumen of a blood vessel. You have to penetrate the blood vessel to get into the lumen. So this is one of the reasons why they consider the lumen to essentially be outside of the body, because you can take a coin from outside of the body, you can stick it in the mouth, you can swallow it, and it will come out the other end. So outside world things come out, go in and come out intact based upon their construction, obviously. Another name for the gastrointestinal tract is alimentary canal. The accessory structures are going to help us with various components of the digestive processes. And so we start in the oral cavity, and we have teeth, we have tongues, salivary glands, liver, gallbladder, and pancreas. So those are the accessory structures. Altogether, they make up the digestive system. We're going to go over some of these digestive processes, and some in more detail than in others. Ingestion, the taking in of food into the mouth or oral cavity, propulsion, swallowing, and peristalsis. Mechanical digestion, we have several processes where we're going to take large foodstuffs and break them physically into smaller foodstuffs, and that's with mastication, which is in the oral cavity, churning, which is in the stomach, and segmentation, which is in the small intestine. I knew you were coming. Chemical digestion, we're going to then, because we've made the big material into small little bitty pieces, we're going to then pour chemicals on them in various areas, and the chemicals involved in the digestion or breaking the foodstuffs down into actually the molecular component are going to be the acidic hydrochloric acid of the stomach and various enzymes, which are going to be also applied to our foodstuffs throughout its transit through the digestive canal. Absorption, that means we want the digested materials that are now in the molecular form moved into the lumen of the bloodstream, in other words, capillaries, and lymphatic capillaries, which we will learn about that they are actually called lacteals. And then defecation, the elimination of indigestible components, just like the coin, went straight on through. Those things that we cannot digest will be actually eliminated ultimately from the gastrointestinal tract. I want to ask you a question about ingestion, taking food into the mouth. What structures are actually involved in that process? In other words, if you didn't have them, would you be able to do it? No, babies don't have teeth. They have no problems with ingestion. No, people have had their tongues cut off and still can ingest. You're going too deep. Lips. You are really going too deep. Think about this, okay? Who has a problem with ingestion? Which newborn will have a problem with ingestion? Somebody with a cleft lip and cleft palate. Absolutely. So those structures are actually have to be intact in order for proper ingestion to occur. Once we get it into the oral cavity, then we're able to actually do some mechanical digestion, because infants, truly, it's digestion mechanically that requires the tongue for initial aspect of things. So that's important. Propulsion, swallowing, and peristalsis. Well, what kind of muscles are involved in swallowing? You only have three muscle types to choose from. One's automatically removed from our list. Skeletal, because swallowing is a voluntary process. So then peristalsis. Peristalsis is the movement of foodstuffs through your lower digestive tract. So that would be smooth muscle. So you have to have proper innervation to those muscles. Mechanical digestion. Mastication is what occurs in the oral cavity, and so that's the same thing as chewing. Churning, that's a process that's done in the stomach. And segmentation, this is a process that is actually done in the small intestine. All of these mechanical digestion components are designed to pulverize food into itty-bitty parts so that we can then apply enzymes and get them actually broken down into the small chemical form that we need in order to then bring them into our body. And that's what chemical digestion is all about. We are breaking our foodstuffs into the chemical building blocks. For absorption. And those also chemical building blocks are referred to as monomers. Absorption, remember, we need to get it into the lumen of our capillaries, and lymphatic, because when we say capillaries, we all should actually think of blood capillaries, and lymphatic capillaries, which you're going to learn are called lacteals. So lymphatic capillaries have a different name for the digestive system than they do in other areas. Defecation, elimination of indigestible components. What if you have an imperforate anus? Do you guys have ever heard of that? So there are actually babies born that have no anal opening. And so defecation is a process that they cannot actually participate in and have to undergo surgery. So all of these things, I know they seem rather simple to talk about, but there are actually people who have difficulties in every single one of these areas because of some sort of congenital defect. Structurally, we're going to talk about the peritoneum. When you hear the word peritoneum, you should think automatically abdominal pelvic cavity, period. It is the lining of the abdominal pelvic cavity, and if it's the lining of the abdominal pelvic cavity, it also lines the organs in the abdominal pelvic cavity. So peritoneum has a parietal component that we've learned all about previously when we talked about the lungs, pleura. We use the term pleura. We have a visceral and a parietal. So same thing with peritoneum. We have a parietal peritoneum lining the cavity. We have a visceral peritoneum lining the organs that actually reside in the abdominal pelvic cavity. So again, remember it's that serous membrane or serosa, and visceral on organ surfaces, and parietal on lining of cavity. And then the peritoneal cavity does contain a little bit of fluid. And what did we call that? What type of fluid would that be? Serous fluid. And it does what we have always learned about. When we have a little bit of serous fluid in any sort of cavity between the parietal and visceral surfaces, that is designed to decrease friction, because we have things that in the abdominal pelvic cavity that move around, and so we want them to move around relatively friction-free so that we don't have any pain. Now, there is an inflammation of the peritoneal cavity called peritonitis. And peritonitis is not a very pleasant experience because when you get inflammation, then you get to have a lot of sensation to the organs that you ordinarily would not even notice when you have peritonitis. So that's typically done because there's been some sort of perforation along the tract. And perforation along the tract means contents of the tract gets dumped into the peritoneal cavity, which causes inflammation and a lot of distress and potential demise of the individual. Now, I wanted to start there because I wanted to go to intraperitoneal and retroperitoneal organs. Intraperitoneal organs are indeed suspended within the peritoneal cavity, have that visceral peritoneum on their surface. Retroperitoneal organs, let's take a look at the notes. It says located superficial to the peritoneum. And so what is the opposite term of superficial? Deep. And so when we say superficial to the peritoneum, we're talking about outside the peritoneum, correct? And so that's what retroperitoneal organs are. And most of the things, retro means the past, like behind you. Most of our retroperitoneal organs, especially those associated with the digestive system, are indeed on our backside. When we get to the urinary system also, all components of the urinary system are retroperitoneal. And so again, you can go ahead with the backside. But you know there's 4 components to the urinary system. There's the kidneys. Do you guys know the name of the tubes from the kidneys to the next structure, which is the bladder? The ureters, and then the bladder, and then the urethra. I said all of those structures are retroperitoneal. Where's your bladder located? It's behind you? Is it on your backside? Is it on the dorsal surfaces?
No.
No, it's on the ventral side. It's on the ventral surfaces, but it's very down low in the pelvic cavity, so to speak, but actually it's slightly above that because whenever your bladder is full, you feel discomfort in your lower abdomen, correct? That is also retroperitoneal. This is hard for you guys because when you see the cat and you opened it up, where was its bladder? Wasn't it right there? It was right there in the peritoneal cavity. And that's a big difference between cat anatomy and human anatomy. Human anatomy, the bladder is retroperitoneal. So that's why having an understanding of retroperitoneal means is important. You won't, when you look inside, if you were to do a laparoscopic procedure, and you looked inside and you were looking for the bladder, you'd never see it. You don't see it until you actually break the parietal peritoneal layer and let it then fall into the cavity for that. Retroperitoneal organs that I want you to know about for the digestive system are the pancreas, the duodenum, and the ascending plus descending colon. This is also different from what you experience with the cat. So make sure that you actually use the cat experience to understand relationships, but understand ultimately how the human is constructed. Mesentery, a fused double-layered section of peritoneum. And so what that is referencing to, here is a space inside, here's a circle, inside the circle is a space called the lumen. And the lining of and this lumen area is our peritoneal cavity. So let's make a lining here. And this lining is meant to be the parietal peritoneum. When you have an organ that actually, and this is how we all start out, we start off as a tube. And when you have now an organ that will now descend into the cavity, and so I'm going to have my organ out here, which started out here, so to speak, and I'm going to move it into the cavity. So it's going to descend into the cavity. What's it going to take with it? It's going to take that serosa, correct? And so that serosa, because it's descending into the cavity, then comes around that organ. And that's what mesentery is. It's a double-layered peritoneal structure. And so the organ now has, this is our parietal peritoneum, and this is our visceral peritoneum, and this here is our mesentery up in this area. And that's how it actually initially starts for us. Let's take a look at some cadaveric photos. What's really interesting about these cadaveric photos is that they show very nicely the greater omentum is a huge apron. All of this here is greater omentum. Do you guys know what the greater omentum is attached to? It's attached to the stomach, and more specifically, the greater curvature of the stomach. That's why it's got the name greater omentum. There's also a lesser omentum, and what would that be attached to? The lesser curvature of the stomach. So it's between the stomach and actually the liver of itself. And that's the same for the cat. And so the cat has a really nice greater omentum that is not riddled with fat. Take a look at that greater omentum there, and some of you, most everybody's been a little exposed to the greater omentum of their cat, and think about the greater omentum of your cat, and think about this greater omentum here of the human. We have a heck of a lot more intra-abdominal fat. It is all over the place for us. And so that's the greater omentum riddled with fat. It is a resource for starvation times. Can you see that? You can actually rob from this when you're undergoing starvation. So it actually helps with nutrition if needed. But for most of us, we are overnourished, so that greater omentum never really serves that kind of a function. But it also serves as a nice mobile apron between our abdominal wall and our organs. And so if you ever have any surgeries, what the surgeon will do after the surgery is done, they will make sure this greater omentum is draped over your intestinal contents as they sew up your ventral body wall, and any adhesions that you get will be to the greater omentum, which is not a big deal because it's a big old blanket that actually can move around quite nicely for you. Another thing, but the greater omentum is actually a form of mesentery. But when you guys think of mesentery, here's one they call it mesentery proper, and indeed, this is the one that's just like the diagram, the goofy diagram I drew up top. This is the mesentery that you are used to associating with the small intestine, correct? And when you take up the small intestine and look at the mesentery in the cat, isn't it nice? You can see the blood vessels in it, and it actually is pretty clear. Do you think that looks the same in the human being? It too is riddled with fat. You cannot see through it, and so indeed our human beings have a heck of a lot more intra-abdominal fat than actually what you encounter with the cat. Yes?
Is greater omentum only attached to the greater curvature of the stomach?
The greater omentum is attached to the greater curvature of the stomach, and is also attached on its other side, because think of it as a big old drape or apron, and then it also attaches on the other end of it to the transverse colon. So, and the transverse colon is right underneath the stomach, so we have this huge drape that's actually overlying all those things. Blood supply. Let's take a look at some terminology here that I want you to always, after you hear these words, I want you to automatically knee-jerk reflex believe that you are dealing with, when the word is splanchnic, gastrointestinal tract arteries. So splanchnic circulation is digestive arteries, digestive system arteries, more specifically the gastrointestinal tract. So splanchnic circulation, this is always arterial to the system. Hepatic portal circulation, this is always venous. And even more specifically, this is venous blood from the alimentary canal or digestive tract that is taking absorbed nutrients to the liver. And that's why we actually are redundant in our class, because typically they just call it portal circulation, but we are redundant because we want to impress upon you that this venous blood is going to the liver before it goes anyplace else. So it comes directly from the gastrointestinal tract, which has just absorbed all of the foodstuffs that you have ingested for your nutrition, and it's going to take it first to the liver before it takes it to the bloodstream. And the reason it does this is because the liver is a processing plant. And you have taken in a whole bunch of foodstuffs that are in a form that needs to be manipulated so that they can be delivered to the tissues properly. You have also ingested toxins. If you have a headache, What will people ingest that's actually toxic for you? Tylenol, so acetaminophen, and also ibuprofen or aspirin. All of these things are going to also be additionally processed in the liver so that their toxic effects can be minimized. So keep that in mind. Splanchnic, arterial, digestive tract, and hepatic, portal, venous, straight to the liver for processing from the digestive tract. Histology-wise, we have mucosa, we have submucosa, we have muscularis, and more specifically, we call it a muscularis externa. I'll talk about that in a moment. And then we have the outermost aspect, serosa, which you know as visceral peritoneum. The design of the digestive tract is going to be for many different purposes. We're going to put food in and we're going to distend various cavities. So we have to be distensible. We also have to move stuff through the cavities, and so that's where our muscularis layer comes from. And then we need, if we're going to absorb stuff, what is it that we want a lot of if we want to have really good absorption? It's called surface area. And so you will find that these, this histology and this makeup will vary based upon where we are in the digestive tract because of what the digestive tract is actually doing. And so surface area is exceedingly important, especially in areas where we're actually having absorption, which is going to be our small intestine for the most part. And then we'll get a little bit of absorption, mostly water in the large intestine. As far as motility, after we have actually voluntarily swallowed, the peristalsis is showing you that we actually have, if we want something to move down the digestive tract, this is moving in this direction. We want to pinch behind it, right back here, and we want to relax in front of it in order to make it move down that tube. And that's what peristalsis is all about. There's another term, I've mentioned it before, but I want you to remember bolus. That's a large volume that is all administered at once. So a bolus. And because you'll hear about people getting an IV bolus. And what that means is we're giving them a large volume of IV fluid and administering it all at one time as a large amount. Mixing is another term for segmentation. And indeed, this is done in the small intestine. And it's basically saying, I'm going to tie down one end and I'm going to tie down another end and I'm going to pretend I have no teeth. And I'm going to mash you to death, which is what people do when they have their teeth pulled, right? They still can actually eat. They still can actually manipulate foodstuffs. They just nosh it or mash it to death in between. And so that's what segmentation is actually all about. Mucosa. Let's take a look, because the mucosa of the digestive tract is really quite different. We do have indeed an epithelial membrane that lines the entire tract, and it will have modifications based upon what's going on in that area. So if we are secreting, that's typically the stomach is what we most commonly think of first. And there's going to be a change in the mucosa for that. And it's because we are secreting acid. And so we have to protect our own mucosal lining whenever we look in that area. Absorption, indeed, there's going to be villi and microvilli to increase surface area. And then protection, we're going to have to make sure that things don't leak in between our cells. And so we'll have a lot of tight junctions in between the cells so that material does not get in between. For the most part, we have down here simple columnar epithelium plus lamina propria. And remember, lamina propria is just that thin CT layer that keeps the epithelium applied. So simple columnar, is that going to be what we have in the oral cavity? No. So in the oral cavity, it's not simple columnar, it's stratified squamous epithelium. But remember, it depends, all of these areas that we're talking about will change some of their construction depending upon our location and what we're designed to do in that area. Let's see here. What do I want to add? Secretion, mucus, that's going to be actually protective. Enzymes, that's going to be digestive. Hormones and acid. So we're actually going to secrete some hormones, and we'll talk about that. Absorption will be of digestive materials. Need high surface area in those regions, and then protection against enzymes, other chemicals, even infectious agents. Simple columnar with lots of goblets. Lamina propria, that's our loose CT, holding epithelium in place. And what's interesting, because this is part of the mucosa, there is a little teeny tiny thin layer of smooth muscle, and we call that muscularis mucosa because it is with the mucosa. It's actually part of it. So a tiny layer of smooth muscle that is designed to enhance local movements and this is going to enhance activity in that area. And some of the activity could be absorption, or increased enzymatic contact. In other words, like shaking and stirring it up. So with the mucosa, we have an epithelium, we have the lamina propria, and then we have this little thin layer of muscularis mucosa. And what it's like, I want you to think of it as it's like a little shimmy machine. And so if you have material on your surface and you want it to come into better contact with little enzymes that are in various crevices of your surface, if you shimmy or shake it just a little bit, things will fall in and be able to come into better contact with items that you want to help with enzymatic digestion, for example. Our submucosa, areolar, which is loose CT, plus dense irregular connective tissue, and that's kind of like what we saw with the skin. Do you guys remember? In the papillary layer, we had areolar, and then we had dense CT. So this construction is very common. It helps with vascularity for the mucosa. And then the dense irregular connective tissue is also going to be used to keep things properly stuck and capable of expanding without ripping and things along that line. In our submucosa, we will find BVs, blood vessels, nerves, and lymphatic structures, lymphatics, plus our nodules. Remember, Peyer's patches is what we're actually talking about. And then muscularis externa, the smooth muscle that is, and we call it muscularis externa because we have a muscularis mucosa. So we want to make sure that we have a proper distinction. But this is the bulk of the muscle of the digestive tract. Indeed, smooth muscle that is responsible for segmentation of the small intestine and peristalsis actually throughout the digestive tract. We have an outer longitudinal layer plus an inner circular layer. There is a nerve plexus. And this is an autonomic nerve plexus that's from the parasympathetic nervous system. And it's called the myenteric. That is going to be the nerve supply for motility. And then the serosa, which is the visceral peritoneum covering all of the abdominal pelvic organs, in other words, those that are suspended in the cavity, but there is part of the digestive system that's not in the abdominal pelvic area, correct? What's not in the abdominal pelvic area that's considered part of the digestive system? Esophagus, and even the oral cavity and things along that line. So realize serosa is for those things within the abdominal pelvic cavity, and with our esophagus, for example, that is covered with adventitia. That is the same thing for the other structures in the mediastinal area. You guys remember what mediastinal or mediastinum is? That's the area in between the lungs. And so the major organs in the mediastinum above the heart, so because the heart's actually in the mediastinum, are going to be our esophagus and our trachea. Both of them are not covered with serosa. They are both covered with adventitia. The regulation of the digestive process is a dual feature. We have nerve and we have hormonal control. And we've had nerve and hormonal control before that we've talked about for our body. So regulation of various processes we already see has a nerve component as well as a hormonal component. The difference though with the nerve component, it's the ANS system that's actually going to be the branch that's going to control the digestive process. And we know that's the parasympathetic nervous system. That's rest, digest. We have receptors for the ANS throughout our digestive tract. So we have baroreceptors that are designed to detect local stretch and pressure. And so when something's in there, that means that we need to start some of our digestive processes, whether it's a physical action or a chemical action. So we have those there. And then chemoreceptors. We also have chemoreceptors throughout the digestive tract that are going to detect the presence of certain things within the digestive tract or within the lumen itself. And so for this, you have to realize we have areas that are going to have suddenly a whole bunch of protons involved in that. So that's basically dealing with the acid that's inside the stomach. And so we have various receptors, chemoreceptors, that can tell us about the various acid levels of the digestive tract. We also have fatty acids and or lipids. So we have various chemoreceptors that are designed to actually detect fat content of our luminal material. And in certain areas, if we have a high fat content suddenly being delivered, we will actually want to actually put in more chemicals designed to help us with fat digestion. So we have those types of receptors too. Hormonal. So what this is talking about is that a hormone is going to be released that's going to cause a digestive process. And gastrin is a hormone that's released by the stomach, and guess what it does? It causes an increase in gastric juices. And so when I say gastric juices, that's going to be hydrochloric acid, and we're also going to learn about pepsin too in just a moment. Secretin and cholecystokinin, these are both released from the small intestine, and they both do the same thing. The only difference is cholecystokinin is a little better at it than secretin is. So of these two, cholecystokinin is better at doing this job of decreasing gastric juices plus increasing the release of bile and pancreatic enzymes. So secretin does the same thing, but it doesn't do it as well as CCK or cholecystokinin. And so put in your notes CCK, cholecystokinin. Because that's what most people say. They're getting a CCK test or something along that line, or they're testing the CCK levels, or they're testing a response to CCK, because it's so much easier to say than cholecystokinin. Moving now into the gastrointestinal tract. We're into the oral or buccal cavity, which we refer to as the mouth. We need our lips to help us with ingestion, and then cheeks to also help us to retain the contents that we've also ingested in. So lips and cheeks are actually a very important component for ingestion. We have a core of muscle that is going to be inside this epithelial membrane covering, which you know is stratified squamous epithelium. And the muscle is going to be under voluntary control. So this core of muscle is actually skeletal muscle. Inside, we have the palate, which is the roof of the mouth or the oral cavity. Anteriorly is the hard palate. Posteriorly is the soft palate. Remember, the hard palate has two bones. It's made up of the maxillary bone anteriorly, for the most part, and then a little bit of the palatine bone on the posterior aspect of the hard palate. Then, as we go further in, or dorsally, we will come to the soft palate. And indeed, the soft palate is an important component that is going to be comprised of mostly skeletal muscle, covered with its own mucosal surface, and it closes off the nasopharynx when you swallow. If you did not have the soft palate doing that for you, when you swallow milk, for example, what would happen? It would go out and down, right? And so that nice little soft palate is doing us a very fine job of closing off that nasopharynx whenever we swallow. Tongue, interesting. You know what kind of muscle is in the tongue, correct? Skeletal muscle, because it's all under voluntary control. And it's an interesting thing. It's also covered with mucosa, yes? And what would that mucosa be? Stratified squamous epithelium. So don't forget, even over the surface of the tongue, we have that stratified squamous epithelial covering. And the muscles of the tongue are interlacing bands, and so they're really kind of a hodgepodge in the direction of the fibers. And because of that, then you can actually have the ability to manipulate the shape of your tongue, correct? So you can actually curl the edges of your tongue, and there's actually some people that cannot do that. They genetically are unable to curl their tongue because it would most likely be to the interlacing pattern is not the same for them as it is for us. And so those muscles of the tongue, which allow you to actually control the shape of the tongue, which is kind of nice to see you guys doing this too, because you're staying awake, you know, you're occupying yourself with other things to do. But that's called intrinsic muscles. So the muscles of the tongue, which are interlacing, are called intrinsic muscles, and they give us the shape of the tongue. But they're extrinsic muscles. And that allows you to not only just curl your tongue, but curl your tongue and stick it out. So the extrinsic muscles actually help move your tongue around. You guys follow that? So the movement of the tongue is actually dependent upon your extrinsic muscles. The shape of the tongue is dependent upon your intrinsic muscles. The combination of the use of the intrinsic and extrinsic muscles help us to mix our foodstuff with saliva and create the bolus. And now let's talk about salivary glands and saliva. We make about 1 liter to 1.5 liters a day of saliva. And saliva is, as you guys all know, is mostly water, but we do have some digestive enzymes called lysozyme inside saliva. We also have a digestive enzyme called amylase in saliva, and we have mucin, which is that sticky stuff, and we have IgA. IgA is immunoglobulin A. That's an antibody that is designed to protect you from the nasties that you sometimes actually ingest, correct? So all along our digestive tract, we actually have IgA being secreted on all of our mucosal surfaces. Now, salivary glands are a really good source of IgA for the oral cavity itself. So what's the monomer look like for an immunoglobulin? What's our cartoon drawing of a monomer? A Y. So what is IgA's most common form? It's a dimer. So we got 2 Y's with the stems attached to each other, and that's IgA. Taking a look at the salivary glands, they are seromucous for the most part. There's only one that's actually serous, and that's the parotid gland. And the way you can tell them is, let's take a look at our histology drawing. Here is a salivary duct, and you see the little opening, the lumen, and you see nice cuboidal cells making up the wall of the duct. So that's how you actually recognize that. The mucus cells are the ones that look more pale pink in their appearance. And then the serous component of the cells are the more purplish, but I'm purplish. I'm abbreviating even purple for you today. So these are, when I take a look at this, we describe this as a mixed salivary gland with seromucous components. So you see, indeed, we have this little mucus center surrounded by a serous aspect of it. You'll still find some pure mucus cells, but the serous cells are also there and typically still associated with mucus cells. So we have 3 salivary glands that you have to identify in your cat, and I also want you to know about in the human. We have the parotid salivary gland right here at the angle of the mandible, okay, from the front of your ear, in the anterior aspect of your ear, all the way down to the angle of the mandible. That's your parotid salivary gland. It's the largest of your salivary glands. It is only serous, so only makes more of what I call the watery fluid for that. Then you have these submandibular, and you can actually feel your submandibular salivary glands. If you'll go anterior to where the angle of the mandible is, and then follow the margin of the mandible, and then just gently push in, you're going to find a little roundish structure that you can actually manipulate and move around. That's your submandibular salivary gland. As we age, have you guys noticed how people get jowly as they get older? Yeah, and you think, well, it's just your skin losing its elastic component. Well, it's not just your skin losing some of its elasticity. Your submandibular salivary gland is no longer tucked up under there so nice and tight. It actually kind of falls down and is actually part of the jowlish look that people actually have. We have serous and mucus components to the submandibular salivary gland. So in other words, it's mixed. So is the sublingual, that which is underneath your tongue. But the bulk of our saliva comes from our submandibular salivary gland. Moving into other structures still associated with the oral cavity. Oh, do you guys know what amylase works on? ACE is an enzyme, right? Okay. What does amylase work on? Carbohydrates. And so when you take a cracker in your mouth, for example, that's starch, which is a carbohydrate. And it doesn't, a nice salty cracker tastes salty. It doesn't taste sweet at all. But if you keep it in the oral cavity long enough to where the amylase from your saliva gets a chance to really work with it, obviously it's very mushy by that time, it'll actually start to taste sweet because it's breaking that carbohydrate down into dimers, which we actually have taste buds for. so we can actually appreciate the sweet taste buds when we break a carbohydrate into our disaccharide. Teeth. Humans have 2 sets of teeth, and we call them dentitions, and that's where dentine gum got its name. It actually used the technical term for your teeth as part of its naming process, so they were pretty smart about that. So dentitions, and when you get dentures, so all of those terminology is actually referring to teeth, so you know that right off the bat. Our first set that comes in, we call that our baby teeth, and they're also called deciduous because baby teeth are meant to fall out or be lost like the leaves of a tree. So we call them deciduous teeth. Do you guys know how many teeth babies are supposed to have when they get total? So 20 by 24 months. Not too bad. It's got to be an even number. So after you lose your deciduous teeth, then your adult teeth come in, and they're called your permanent teeth because you're not supposed to lose these. These are the ones that you're supposed to have with you all the way throughout your life. And this is 32, typically by age 18. So, there's always variation, but this is the generalization that you can learn, and then you'll experience variations throughout life. The teeth are given names for their appearance and therefore what they can do for you. Our front teeth are called incisors, and so we have a total of 4 on the top and 4 on the bottom, and they have cutting edges. It's really hard to bite into an apple without your incisors, designed to actually cut into those types of things. Canines, these are obviously pointed, and they are for piercing and tearing. Then as we go back and follow the dental line, we have premolars. They are also referred to as bicuspids. So they have 2 points on them for grinding and crushing. And then back behind them, those are our molars, and these are the largest of all of our teeth and the best ones for grinding and crushing. So we'll stop there. We'll get into tooth structure on Wednesday, and I hope you guys get a chance to enjoy some of our sunshine today.